All right, so they can rejoin us back. But for now, let's get moving. So please, when you're coming to the meeting, you can permit recording to be done. But if you don't want to be recorded, then there's no need joining. So let's move. So we're going to start the immunology today. Now, see what I want you to understand. We've started. Now, what I want you to understand is this. When you talk about immunology, immunology has to do with the immune cells, which are basically the white blood cells. Those are the key players in immunology. Now, there are two types of white blood cells that are basically called lymphocyte. That is the B lymphocyte and the T lymphocyte. Have you ever wondered why these guys are called B lymphocyte? Why are those other ones called T lymphocyte? Now, see what I want you to understand first of all your blood cells are produced in the bone marrow. Let's assume this is the bone marrow here. This is where all your blood cells are produced. These blue ones are definitely your B lymphocyte. The red ones are your T lymphocyte. So all of them are produced at the level of the bone marrow. Now, after production, it does not mean that they are mature. They are immature after production. They need to undergo certain processes before they can definitely be termed mature cells. Now, that brings us to the concept of the primary and secondary lymph organs. Now, when we talk about the primary lymph organs, the primary immune organs rather, so there's primary and secondary lymph organ or immune organs. Both names can definitely be used interchangeably. Now, when we talk about the primary immune organs, these are definitely organs that this lymphocyte go to for maturation after they have been produced. Now, there are two basic organs that can be termed the primary immune organs or the primary lymph organs. That is one, the bone marrow. Then the second one is your thymus. This one here in black too. Now see, all your lymphocyte, whether the B or T, will be produced in the bone marrow. But after production, your T lymphocyte cannot be matured in the bone marrow. Your T lymphocyte will rather migrate to the thymus. It is in this thymus now your T lymphocyte will mature. Now, your B lymphocyte will remain in the bone marrow and undergo maturation and differentiation in the bone marrow. Now, the lymphocytes are named after the organ they undergo maturation in. That is why your B lymphocyte are called B lymphocyte, because they are the bone marrow lymphocyte. They undergo differentiation and maturation in the bone marrow. Now, that is why your T lymphocytes are called T lymphocyte, because they undergo differentiation and maturation inside of the thymus. T for thymus. Now, after these cells has undergone maturation, now they have been converted to mature B cells or T cells. What you need to understand is this: it is not in the thymus they will function, neither is it in the bone marrow they will function. Now, what will happen is that they will have to be moved to a temporal site where they can be stored, so that if there's a problem, they can definitely be released from there. Now, just imagine, let's use the US, because that is where all of us are definitely planning to move to. Let's use the US as example. Let's say the US ordered for production of AK-47 rifle for its military. Now, let's assume that the factory that produces the AK-47 produced 1,000,000 pieces of the AK-47 for the US military. Now, after producing that gun, in the factory and the gun undergoes modification and final testing in the factory, the gun is not supposed to be kept in the factory. It is supposed to be delivered to US Armory. That is where you're going to store those weapons so that if there is any challenge, the US soldiers can pick those weapons from the armory and definitely use it to defend the US. That is exactly what happened. Now, the immune cells undergo maturation in the primary lymph organs, but immediately after they have undergone that maturation, they will migrate into the secondary lymph organ. Now, coming into the secondary lymph organ, they are definitely stored here, waiting for when there's a problem. So both the B cells and the T cells will definitely be stored here because these ones now are mature. Now, this is where they are stored until there is a signal that, yes, there is problem. Once they get that signal that there's problem, this is where they will become activated. At this point, they are not yet activated because there's no problem. But just create a problem, automatically they will be activated. And once they are activated, they are moving to quickly handle that situation. So now your secondary lymph organs are definitely where you have storage of the lymphocyte after they have undergone maturation. That you need to understand. Now let us move on. Let us look at this secondary lymph organ. What are the secondary lymph organs basically? That is where you have the like of your spleen. Very important. That's where you have the like of your lymph nodes. Very important. And that's where you have the like of your Peyer's patches. This is going to be in the GIT. Now, let us look at two of those secondary lymph organs in details. Let's look at your lymph node and let's also look at your spleen. Sorry, I like doing most of my teaching at the level of the whiteboard. For those of you who have the literature, this is first aid. You can definitely be looking at the literature while I do my teaching. My pattern is that I move from the top towards the bottom. I'm explaining the pages, but I don't have to be reading it out for you. I have to give you the explanation. You have the text. So I always move from the top towards the bottom. So if you're with the book, you can definitely be looking at it while I'm doing the explanation at the level of the whiteboard. Now, let us look at the lymph node. Let us start with that. Now, you need to understand what is important for the pathway. A lot of persons on this platform are definitely IMGs, international medical graduate. The things that are important in your country and in your medical school may not be the focus in the US. So you have to know what is the focus in the US. Now, when you look at your lymph node has a lot of structures. For example, your lymph node will definitely have the efferent and the efferent. Efferent is definitely the outflow. Let's say the efferent is definitely the inflow channel. So things flow in via the afferent and it flows out via the efferent. So the immune cells enter the lymph node via the afferent, and when there's problem, it flows out via the efferent. So this is the efferent. This is the afferent. Now, these are not the things that the USMLE is interested in. Now, the things the USMLE is interested in is what is the structure of this lymph node and how do you correlate them with the different immunologic processes and different infective processes. This is what is important. And that is where we're going to be focusing our energy on. Now, looking at the lymph node has two basic divisions. So let me just represent the lymph node like this. Let me use this as a crude structure. Now, there are two basic divisions the lymph node has. This one in blue in the middle. This one in blue in the middle is what we call the medulla, which is the inner portion. Now, this one in red here, this white space first, this outer white space, this one here. Okay, let's say this portion in red is the cortex. That is the outer space. Now you see this portion in white that is between the cortex and the medulla. That is the one you call the paracortex. So this blue here is the medulla. This is where it's getting interesting. This red here is the cortex, the outer. And this white here is the paracortex. Now see what you need to understand, and I will tie in a lot of important concepts as we flow. Now, at the level of your cortex is where you have your B cells. Now, your B cells do not exist in isolation. The B cells exist as a collection of B cells that is called the follicle. Look at this. This has a lot of B cells inside of it. If you see this, if you see what I'm drawing, there's a lot of B cells inside of this. It will be collected in this thing we call follicles. Now you have a lot of follicles in the lymph node. So the B cells, their space is definitely inside the follicle and in the cortex. Now, what you need to understand is there are two types of follicles. There's the primary follicles and there's the secondary follicles. The primary follicles is when the B cells are not activated. They are just in that follicles. Nothing is happening. They are just chilling. That is called the quiescent follicle. But now, if there is a trigger that there's a bacterial infection, automatically the B cells become activated. Now, when the B cells become activated, that follicle move from inactive follicle to active follicle. That active follicle is what is called the secondary follicle, or it is called the germinal center. You should not forget this name, the germinal center. Now, the process that causes the inactive follicle to move to active follicle is called the isotype switching. So active follicle goes to inactive follicle rather goes to active follicle via the process of isotype switching. This is definitely what you need to know. Now, let me show you this thing from the literature, this image. Look at this follicle here. This is a follicle, this one that is white here. This whitish follicle here is definitely the inactive follicle or the quiescent follicle. Now, this one here, you see this one here is still a follicle, this one here. But this one now, you can see is giving certain form of coloration. It is more bright. This one has definitely been activated. This is now the germinal center. And if you get a clinical vignette in your MPME, in your UWorld, and they're asking you what is happening here, they can label this point and ask you what is happening here. It is going to be the iso switching, because that is when this follicle move from the inactive to the active. That is what they want you to know. That is the things that are important. Now let's go to the whiteboard and continue the party. That's where the party is happening. So we've settled the follicles and the cortex. Now, the medulla is just where you have the macrophages, basically. The medullas are not so much important. That's where the macrophages are chilling. But now, see where is very important too, the paracortex. At the level of the paracortex, this is where you have your T cells. These are the T cells occupying here. So the T cells are at the level of the paracortex. Now, let us integrate some immunology concepts and some infection concepts into this thing so that it makes sense. Now, if somebody has bacterial infection, if you have a bacterial infection, it is your B cells that will respond mainly. because your B cells will have to produce antibodies that is going to handle that infection. So once you have bacterial infection, your B cells response produces antibody. Now, what of if you have a viral infection? If you have a viral infection, your B cells are not the ones that respond. It is basically your T cells that take care of viral infection. Now, see where this thing is important. Look at the application of this statement I have made. If you have a patient that comes to your hospital and the patient has an infection, be it viral or bacteria, most of them will have lymphadenopathy. That is swelling of the lymph node. It shows signs of infection. Now, the question is, why would the lymph node be swollen? Because you have proliferation of the immune cells in that lymph node because they are being activated rapidly. Now, see what you need to understand. If you're giving a clinical VNet and the person has a bacterial infection and they're asking you what is causing this lymphadenopathy, it will be the swelling and proliferation of the follicles. Is a bacterial infection, is the B cells that will respond. So it is the follicles that are proliferating. That is why that particular lymph node is getting swollen. How would you know it's a bacterial infection? They can give it to you 100% by telling you, oh, the person has staphylococcus infection or this or that. Or the likes of you or an MBMA can also coin it in such a way that they can tell you the person had purulent discharge. Pus is caused by dead neutrophils and bacteria. Whenever you see pus, it's a bacterial infection. Under that condition, you can definitely go with proliferation of the follicles. Now, on the other hand, what of if that person has an upper respiratory tract viral infection, like the person has Epstein-Barr infectious mononucleosis, and the person is having lymphadenopathy? The follicle has no business in that lymphadenopathy. That lymphadenopathy is caused by proliferation of T cells in the paracortex. So it's going to be hyperplasia of the paracortex that will be causing it in that particular patient. Now, that settles that. Now, let us also look at certain type of immunology concept too that can also be related to this lymph node secondary structure. Now, there's a particular condition we call the DiGeorge. Permit me to clean some of those things away because I want to use this diagram to still tie all the things I want to tie in. Now, there's a particular immunologic condition we call the DiGeorge syndrome. Now, in the DiGeorge, why is my pad hooking? Okay, it's good. Now, this DiGeorge syndrome, one of the problems is this. These guys do not have thymus gland. The thymus gland is absent thymus. Now, think about it. If these guys does not have the thymus gland, what do you think would happen to your T cells? You're not going to have mature T cells because from what we talked about previously, the thymic gland is a primary immune organ that is responsible for causing maturation of your T cells. That is why they are called the T cells, thymic cells. So if this guy does not have thymus, automatically this guy cannot have mature T cells because there is nowhere for T cells to undergo maturation. Now, if that is the case, what it simply means is that there will be no T cells to occupy this paracortex because the T cells that you see in the paracortex are mature T cells. So there will be no T cells in this paracortex. If there's no T cell in this paracortex will definitely go away. There will be atrophy of the paracortex. That is what you see in the DiGeorge. Remember, if it is a viral infection, you will see hyperplasia or hypertrophy of that paracortex. And you know why. T cells respond to viral infection. So this is everything on this page explained. We have been able to tie in everything on this page, starting from the immune system organs down to the paracortex. That's everything. So let's move on. Let's keep going. Now you see this particular page. I am not um I'm not a party to cramming. For people that know me and know me very well, I don't like cramming. Like I hate cramming so much. And if you want to cram in this pathway, you're going to have a lot of problems. The reason why you're going to have a lot of problems is this: how many things can you cram? The pathway is vast. The pathway is like everything you did in your entire medical school. Medical school in my home country is 6 years. Can you cram everything you did in 6 years? It's not going to be possible now. So I always advocate, try to understand. It's only if that concept is a concept that needs memorization, you can now memorize. But if there's a concept behind it, understand the concept so that when you're in the exam, you can always work out things from the very first principle. Now, this particular page is a page that you're going to do when you cover the entire systems. For example, if I start telling you the lymphatic drainage to the lungs, you're only going to be cramming it. But by the time we do respiratory system, you understand that the lungs will go to the hilar. If I tell you that the GIT, the liver, the stomach, the spleen, the pancreas will go to the celiac trunk, at this point, you're going to be cramming it. But by the time we do the GIT, you will understand that the GIT is divided into the foregut, the midgut, and the hindgut. And in the foregut, you have the esophagus, you have the stomach, you definitely have the pancreas, you have the gallbladder, you have the liver, you have the spleen. Lymphatic usually follows their artery. So if the celiac artery is supplying the foregut, the celiac trunk, that is the lymphatic, should also drain the foregut. When we finish all the systems, we cannot look at this page. And at that point, you look at it with understanding. If you're looking at it now, you're only cramming it. So we're going to pass. Now, when we move on to the next secondary lymph organ, this is where we talk about the spleen. So let's go to the whiteboard again and let's continue the party at the level of the whiteboard. Now, looking at the spleen looks similar to your lymph node. I'm not going to be talking a lot of things because I've already explained it at the level of your lymph node. I will just tell you the things you have to know. Now, let's assume this one is the spleen. Now, the spleen has two main divisions. There's what we call the red pop. These areas here can be the red pop. And then this one that is in blue here is the white pop. This is the white pop. Why this is the red pop, basically. Now, what I need you to understand is this. Your B lymphocytes and your T lymphocyte, both of them are contained in the white pop. They are not in the red pop. Now, your B lymphocyte, as usual, will be contained in follicles. These are follicles. This one has your B lymphocyte, just like in the lymph nodes. Now, what it simply means is that if this person is having a bacterial infection, it is the follicle that will definitely enlarge, but you will not have splenomegaly, please, in somebody that has infection. That is not going to be true. If somebody has infection, the spleen will not enlarge. The spleen is too big for enlargement of the follicle to cause it to expand. It is only the lymph node that is small, that once you have proliferation of follicle or hyperplasia of the paracortex, it will enlarge. That is not going to be in the spleen. But all you should just know is that the follicles is where you have the B cells and they will proliferate in bacterial infection. Now, you definitely have the paracortex. You have the not paracortex. Now, in the spleen, you have what we call the PALS. That is the PALS. Sorry, I will unmute. My network is not so good. Okay. If there's network failure, no, I will not unmute the house because some persons will cause some distraction. If there's network failure, please drop it on the general page. If the network goes off at any time, drop it on the general page so that you call my attention, because I'm unable to see the meat. This is the only screen I'm able to see. Now, there's what we call the PALS. The full meaning is the periarteriolar lymphatic sheath. This is somewhere around this region. That is where your T cells are. So if you have a viral infection, that is where the T cells will definitely proliferate. Now look at where the whole concept is in the spleen. Let us start talking about the anatomy. Let us start talking about the function of the spleen. This one is part of the function, like it is a secondary lymph organ. It has the B cell, it has the T cell. B cells in the follicle, T cells in the PALS. But the function of the spleen is way more than that. So let's start with the anatomy. Now, if you look at the abdomen generally, you can divide the abdomen into 9 quadrants, basically. You can divide the abdomen into 9 quadrants. For those of you whose exams are very close, you will need to know this because they can be lifesaver. Now, let's say this is the left, let's say this is the right. So this is the left upper quadrant. This is the right upper quadrant. And this is the epigastric. This is definitely the umbilical. This is the left lumbar. This is the right. This is the left or iliac. This is the suprapubic. This is the right lower quadrant. This is the left lower quadrant. I have to tie in this quickly for you at this point so that you understand certain things while we move on. Now, at the left upper quadrant is where you have your spleen. This one here, the spleen, is what you see here. At your epigastric region is where you have your pancreas and your stomach. So if somebody has pancreatitis or somebody have gastric ulcer, the pain is going to be at the epigastric region. At your right upper quadrant is where you have the gallbladder and the liver. So somebody that has cholecystitis, the pain is going to be on the right. Now, your umbilical region is where you definitely have the intestines all around those regions. If somebody is having pain in the loins, you should be thinking of the kidneys. The suprapubic region in men is where you have the bladder, basically, but in female, you have the bladder and the uterus. So if a woman has suprapubic pain, it can be a pain from the bladder or pain from the uterus. Now, in the right lower quadrant, that is where you have the colons that are ascending. For example, your second and your ascending colon, they are on the right. That is why you're going to have acute appendicitis pain on the right lower quadrant, because the appendix is definitely an offshoot of the second. Now, on the left lower quadrant is where you have the colons that are descending, the sigmoid colon, the rectum. That is why you're going to have diverticulitis on the left lower quadrant. Now, this is the one that is interesting us in this particular class. This is where the spleen is going to be, in the left upper quadrant. Now, your spleen will run from your 9th to about 11th rib. This is what protects the spleen on the left. Now, my question to you is, aside that immune function we have discussed, what are the other functions of the spleen? Now, see what I want you to understand. The spleen is responsible for taking out encapsulated organisms, organisms that have capsule. It is very hard for the body to handle encapsulated organisms. My question to that is, why is that so? Now, I want you to look at this scenario. This is a bacteria here. This guy here is your immune cell. Your immune cell can recognize, okay, let me add something to that. This is your normal cells in black. This is your bacteria in red. This is your immune cell in blue. Your immune cell can look at this red cell and say, no, this is not the normal cell. Come on, take it out. And it will take it out. The bacteria is gone. But now look at what you should understand. This bacteria can become wise and acquire a capsule. Now, when these bacteria become wise and acquire a capsule, this is what will happen. The bacteria will now have a capsule surrounding it. Now, because of this capsule it has surrounding it, the immune cells cannot tell again that this particular bacteria is a bacteria because it is seeing this capsule looking similar to this normal cell. So automatically your immune cells will not destroy this encapsulated bacteria again. This bacteria now would have avoided phagocytosis. You can't phagocytize it. It's not possible. Now you can see that it has escaped phagocytosis. Now what it simply means is that the bacteria will keep on reproducing. It will continue to reproduce and it will now cause an overwhelming infection that may likely kill that person. Now that is where the spleen comes in. Now this is what the spleen will do. Let's say this is the spleen at this point. Now the spleen will cause activation of complement. Please, it is not fixing of, it is not production, rather, it is fixing or activation. Please, production of complement is done in the liver. What the spleen does is it causes activation of complement. Now, in the course of that activation of complement, the spleen is interested in producing your C3b complement protein. Now, when the C3b complement protein has been produced, now the C3b is like a scanner. What the C3b will do is that the C3b will come and scan this guy here. When it scans this guy, it will see that this guy is normal. Oh. This guy is no problem. The C3b will come and scan this other guy here. When it scans this guy, it will now discover that, oh, this guy is discarding. He definitely have a lot of things under it. This is not a normal body cell. This is a bacteria. Now, what the C3b will do is the C3b will attach itself to this encapsulated organism, and it will now raise alarm and tell the immune cell that this guy is definitely a spy. This is a bacteria. Come and take it out. Immune cells will now come and take out this encapsulated organism. Now, this function is what we call opsonization. So the C3b acts as an opsonin. Now, imagine that you don't have the spleen. The spleen is gone. Now, if the spleen is gone, of course, you're not going to have this effect anymore. What it simply means is that this your encapsulated organism, there is no way of eliminating it again. So it will continue to replicate until it will cause an overwhelming infection and kill this person. So the spleen is responsible for taking out encapsulated organism. And in people that have the spleen removed, either functionally or surgically, functionally is that you did not do surgery, but the spleen went away on its own. Classic example are people that have sickle cell anemia. They have autosplenectomy. Now, if somebody has a road traffic accident and had splenic injury and you did a surgical splenectomy, for those type of patients, for them to be alive and remain alive, you have to give them vaccine for encapsulated organism. There are three important encapsulated bacteria that will keep causing problem for them. That is the pneumococcal. That is streptococcal pneumococcal. That is your Haemophilus influenza type B. It is not all Haemophilus influenza that is encapsulated. It is the type A. which is the type B that is encapsulated. And finally, your Neisseria meningitidis bacteria. This is also encapsulated. You must vaccinate this person for these three encapsulated organisms. Now, the function of the spleen does not end there. Now, if you look at your red blood cells are anucleated cells. What it means is that this is how your red blood cells are. Your red blood cells are like this. They don't have a nucleus. It is the red blood cell is one, one very wonderful cells. If you get to understand it, it is very different from a lot of cells in the body. Normal cells will have nucleus. This one will fail to have nucleus. Normal cells will have MHC class 1. The red blood cell will not have MHC class 1. Almost all the cells in the body uses alternate form of energy other than glucose, including the brain. The brain can use ketone, but you see the red blood cell will only use glucose. If you don't have glucose, it will refuse to use any other thing. This is how the red blood cell is normally. It is anucleated, no nuclear remnant or whatsoever. But the truth is that this is not how it is produced. Look at the way the red blood cell was produced. It is produced like this. This is the immature red blood cell that is leaving the spleen. Sorry, that is leaving the bone marrow rather, because red blood cells are produced at the level of the bone marrow. So these are the immature red blood cells. These are the immature red blood cells leaving the bone marrow. Now, they have what we call nuclear remnant, small nuclear remnant that is left. Now, these red blood cells will come to the spleen. When they come to the spleen, it is the spleen now that we take out that nuclear remnant and push them to the peripheral circulation as the mature red blood cell without any form of nuclear remnant. So think about it. If the spleen is not there, you have surgically removed it, or it is not working again, automatically you're going to get red blood cell in the circulation that still have nuclear remnant. That is what is called the Howard-Jolly's body. That Howard-Jolly's body you see they talked about, that is what it is. Now, the other thing is this. The spleen provides a temporal storage site. It provides a temporal storage site for your blood cells, especially platelets and white blood cell. Now, let's assume you have a total of 500,000 platelets in the body. I'm not saying that is what you have in the body. Normal platelet count is between 150 to about 400, 450, depends on the lab. But this is a teaching purpose. So let's assume that what you have is 500,000 platelets in the body. Now, of these 500,000 platelets you have, 40% will be stored in your spleen. The other 60% will definitely be sent to the peripheral flow. So if 40% of 500 is stored in the spleen, meaning you have 200,000 platelets in the spleen, while you will have 300,000 in circulation. Now, when you look at this 300,000 in circulation, it is normal because the normal one is between about 150 to 400,000. So 300,000 is normal. But what you need to understand is that it is normal because the platelet is holding 200,000. Just in case there's a problem, the platelet will have to release that while we're waiting for the bone marrow to produce more. Now, see what you should understand. Imagine that this person now had an injury and they took away the spleen. What it simply means is that there is nowhere to store those 200,000 the spleen used to store before. So all the platelets, the 500,000 platelets will now be dumped into the blood. Automatically, that will definitely give you a high platelet count. That is what we call thrombocytosis. The same thing is applicable for your white blood cell. You also have lymphocytosis. Target cells is when you definitely have trimming of the red blood cell membrane. Now, I have been able to talk about the entire spleen at the level of that whiteboard. Like I said, you have the literature. The literature is what you have. If you don't have, you can definitely buy a copy of First Aid. You can buy the online version. They have soft copies. My own is not to come here and read the literature for you word for word. My own is to come and explain the content of the literatures, the way it should make sense to you. Now, let's look at what we have below. What we have below is the timers. Do I need to go to the whiteboard to play with this? No, I don't think we can do this here. Now, when we look at the thymus, what you need to understand is this. The thymus is seen in the mediastinum. This is funny, but it's true. Some medical students and some doctors don't even know where the thymus is because it's not something that we talk about regularly. It's not something you will see in a chest x-ray in an adult, but it is in the chest. It is in the mediastinum. That is the space in between the lungs and the chest. That is where it is. Now, you can visualize the thymus in a child that is 3 years and below if you do a chest x-ray for them. But once a child gets above 3 years, you're not going to see that thymus again on a chest x-ray. That is why we don't get to talk about it often, because we don't see it on x-ray. When we do our normal patient chest x-ray, we see the lungs, we see the heart. Those are the ones we get to talk about regularly as members of the thoracic cavity, but the thoracic cavity contains more than that. Now, you should understand that the thymus is where you have maturation of your T cells. That's why the T cells are called the thymic cells. Now, the thymus has a cortex and a medulla. The cortex is where you're going to have the immature T cells. The medulla is where you have the mature T cells. We're going to talk about that in detail. I will play with that concept in details when we get to the differentiation of T cells. That's where you will see that the positive selection happen at the level of the cortex and the negative selection happen at the level of the medulla where you have the mature T cells. Just don't worry, we're going to play with that in depth. Now, of course, you know, somebody that have the DiGeorge syndrome is not going to have the thymus. There's thymic aplasia in that disease. You can also see thymic aplasia in SCID. Now, when somebody have neoplasm of the thymus gland, which is called thymoma, the person can have what we call paraneoplastic syndrome. Paraneoplastic syndrome is that you have a neoplasm, a tumor, and that tumor is giving you clinical presentation that are completely different from the organ that tumor is affecting. For example, you have the small cell lung cancer in the lungs, and that small cell lung cancer is giving you Cushing syndrome. It's causing your adrenal gland to produce a lot of ACTH, and it's causing Cushing syndrome. The lungs has no business with the adrenal. So that is what a paraneoplastic syndrome is, a tumor causing a clinical presentation that is completely different from the organ it is affecting. Now, if somebody has neoplasm of the thymus, the person can have myasthenia gravis. In fact, if you see a patient with myasthenia gravis, you will definitely have to do a chest CT scan to check for thymoma. Now, it will cause the pure red cell aplasia or the good syndrome. This should not bother you so much. What should bother you is definitely this association with myasthenia gravis. And we're going to dine on this concept in the musculoskeletal. We're going to sleep on that concept. Now, if that is understood, let's get the ball moving. Now, let us look at the concept of the adaptive versus innate immunity. Now, a lot of people confuse innate immunity and adaptive immunity between passive immunity and active immunity. Now, adaptive immunity and your active immunity have a lot of similarities. But the passive immunity and the innate immunity are completely different. Now, let me bring the three of them at the level of my whiteboard and compare the three of them briefly. Then we'll now start talking about the innate immunity in depth. Now, I just want to give a summary, like an overview of the three of them. This is, no, let's start from innate. Let's start from innate. This is innate immunity. This is passive. This is adaptive. There are the three I just want to give a run through. Now, let me start from the innate. I would use a normal day-to-day example to explain it before we start driving it down. Now, in general, innate immunity are those immune processes you're born with. They are already functional at birth. You did not do anything to have them. You just have them like that. They are yours to enjoy from birth. Now, your passive immunity is that you acquired it. Somebody worked for it and gave it to you. You're enjoying somebody's sweat. Now, the adaptive immunity is that you worked for it and you're not enjoying it. But the thing is that you were the one that worked for it. Now, let's use a normal day-to-day example. Let's use the US, for example, since that is where all of us want to go to. Now, if you're born as a US citizen, there are certain privileges that you have as a citizen. Whether your father is the president of America or whether you're the son of a homeless man, as long as both of you are from the United States, both of you have those privileges to enjoy because it is something that every citizen must have. That is comparable to your innate immunity. Everybody have it. It's functional from birth. You did not work for it. As long as you're a human being, it is there. You have it. Now, let us look at the next one. The son of a homeless man cannot enjoy the privileges the son of Elon Musk will enjoy. It's not going to be true. It's not possible like that the son of a homeless man will enjoy the same privilege as son of Elon Musk. That's not going to be true. Son of Elon Musk can go to Mars for tourism. The son of a homeless man can only stay on the ground and look at the rocket moving to Mars, but he cannot enjoy that. Now, the son of Elon Musk never worked for any of those things. Maybe it's just a 5-year-old boy that doesn't even know what the definition of work means, but he's already enjoying rare privileges. That is because somebody worked for it and he came to enjoy another person's work. That is what passive immunity is. In passive immunity, for example, the mother developed immunoglobulins and transferred it to the fetus or to the child via the breast milk or transplacenta. The child never worked for that immunoglobulin for 1 day, but the child is having full protection because of that immunoglobulin he or she received from the mother. That is passive. Now, when you look at the adaptive is that you have to work for it. You have to work for every single penny. Every single penny. You actually came from a humble background, just like the Tyler Perry, the guy that does the Madea movie. You would have heard his story, but today he's worth almost $1 billion. That is adaptive immunity. He worked for every single dollar bill he made. He never had that privilege. He worked it out. You can compare that to adaptive immunity. Now, if you understand things from these simple basics, you can relate it with normal life experiences. It is easy to work it out. Now, let me delete the passive immunity. We're not going to talk about this today. I just brought it because a lot of people confuse innate and passive. Now, let me focus on the innate first. Now, there's a way I normally do my teaching. If we're faced with a table like this, I start talking about them one after the other, and I start from top to bottom. So I'm going to start with the innate immunity. In case you're using the literature, you can flow with me. I'm going to start from the innate immunity, and I'm going to talk about it from component down to the key features in pathogen recognition. When I'm done, I'm going to switch to the adaptive immunity, and I will also do it from the top to the bottom. Please, um, please bring down your hands. I don't like distraction. You make me lose my line of thought. You have opportunity to ask question at the end of the class. Thank you. So now let's get the party moving. So let's start from innate immunity. That's what we're going to be talking about now. Now, when we talk about this innate immunity, these are the things you have right from the time you were born, and they are working from birth. It's not that they started working later. One of the component of innate immunity that people fail to understand, that is a very important component of innate immunity, is your skin. See, your skin does a lot of job. Your skin protects microorganisms from gaining access into your body. That is the reason why God gave you the skin. If the skin was not there, microorganism would just have access into your body. That is why burns people are managed in specialized area, sterile area. And even though they're in that sterile area, they still come down with infection commonly as compared to the normal person. Now, the other ones that are components of the innate immunity are definitely your phagocytes. Phagocytes are basically neutrophils and macrophages. These are the two predominant phagocytes. Now, there's also this member of the lymphocyte that is called the natural killer cells, NK cells. NK cells are also members or components of the innate immune system, including your complements. So at birth, you have all of those things and they are functional. A newborn has an intact skin. As long as he's a human being, he has all these things. And at the time he's born, all of them are functional ASAP. Now, these things, he already had them encoded even before he was born. So this is like germline encoded. Germline is that you have this thing encoded even before you were born. That is when you were being formed. All this thing was programmed. It is not something that you add later on. From the time you were being formed in the womb, all of these things has already been programmed. And as you're coming out of the womb, you have them to enjoy. Now, if you look at the way the innate immune response work, the innate immune response is extremely fast, but it is also non-specific. Now, if there is an infection, the first person to respond is the innate immune system. Neutrophils will definitely be migrated to that place immediately. But what you should understand is that neutrophil is not specific. What neutrophil know is that this thing is bacteria, fight it. So whether it is staphylococcus, whether it is streptococci, whether it is pseudomonas, as long as it's a bacteria, neutrophil will keep fighting them. And because it is not specific, it will have no memory. So look at it, because it is already programmed, you already have it. It can be activated in a matter of minutes to hours. So it is very fast, but it is non-specific. It fights everybody at the same time. And it keeps no memory. That is going to be important when we start comparing it. to our adaptive immune response. Now, another thing for you to know is how will the cells that are responsible for carrying out the innate immune response be activated? Those two cells are basically your neutrophils and your macrophages. How on earth will these cells be activated? Now, this is your neutrophils or your macrophages. Let's call them the phagocytes. So I'll put P here. So phagocytes. Now, the neutrophils and the macrophages have a particular receptor we call the toll-like receptor. That is the TLR. That is what a lot of literatures we call it, but the full name is the toll-like receptors. Now, what you need to understand is this. This is what is very important. Now, the neutrophils and the macrophages are activated under two conditions: when there is a disease process or when there is an infective process. Now, the neutrophils and the macrophages are phagocytes. They don't just phagocytize infective organism only. They can also phagocytize normal body cells that are diseased and wants to be taken out. So these particular toll-like receptors respond to two types of stimuli, depending on what type of cell it wants to remove. Now, if it wants to remove an infectious agent, let's say this is an infectious cell, this is a bacterial cell. Let's say this is a gram-negative bacteria. Gram-negative bacteria on their cell wall have what we call the LPS. Now, this LPS contains a particular pattern. That pattern is called the pathogen-associated molecular pattern, PAMP, pathogen-associated molecular pattern. Let's just assume this is, let me take this thing one step further. Let me assume this is your toll-like receptor. Now, in your toll-like receptor has two things that are abnormal, two particular sequences that are abnormal. Let's say this receptor is programmed that anything that has 1, 2, 3 is infective, and anything that has 4, 5, 6 is diseased. I'm just saying this is how it is programmed. I'm just trying to explain to you for you to understand. Now, if a cell is normal cells in the body will never have this pattern, either 1, 2, 3 or 4, 5, 6. So if a normal cell interacts with this particular toll-like receptor, the toll-like receptor will not be able to pick out any of this pattern 1, 2, 3 or 4, 5, 6 from the cell. But if it is a disease cell, let's say this is the pattern for disease cell. Once a cell becomes diseased, it will have what we call the disease-associated molecular pattern. It will now develop the 4, 5, 6 sequence. So when it binds to this toll-like receptor, the toll-like receptor will recognize it and say, oh, 4, 5, 6 is diseased. That cell is diseased. We need to take it out. It will be activated and it will take that cell out. The same thing too, when bacteria bring the like of their lipopolysaccharide that contains the PAMP, that is the pathogen-associated molecular pattern, which is the 1, 2, 3. Once it binds to this toll-like receptor of the neutrophils or macrophages, they will definitely recognize it and say, oh, this sequence is definitely abnormal. This is definitely a bacterial cell because this is the pathogen-associated molecular pattern. Immediately they are activated and they will take that cell out. This is how the innate immune system works. I believe I've been able to sort it out from top to bottom. Okay, so the thing we missed out is the secreted proteins. So lysosome, the C-reactive protein, and cytokines are the ones that work here basically. So we have been able to take out the innate immune system. Let's look at the adaptive immune system. Now, there's no need of going to the whiteboard to play with the adaptive immune system. We're going to talk about the adaptive immune system in more details as we move. In fact, the immunology concepts are basically tailored towards the adaptive immune system. Now, when you talk about the adaptive immune system, these are the ones you have to work for. These are the ones you work for. Your body will have to develop it. The truth is this: if you bring a child from Africa, from a very humble background, from Africa or maybe from Asia, and you compare the immune system of that child to a middle class child in the US, the child from Africa has a very superior immune system because he has come in contact with a lot of things and he has developed a lot of antibodies. He has developed a lot. That is what the adaptive immune response is. Anything that don't kill you makes you stronger. Once you come in contact with that microorganism, once it is unable to kill you, your body will definitely develop immunoglobulins that will handle it. And once that immunoglobulin has been developed, the body will store some of it as memory cells so that whenever you see this guy again, will activate immediately and shut it down. That is what the adaptive immune system is. You work for this one. You develop it as you grow. You develop it by encountering different types of pathogens. Now, the response initially is not very rapid. The first time you come in contact with that pathogen, the response is not rapid. The reason is that it takes time to produce antibodies that are specific to that organism. For example, antibody against Staphylococcus aureus is not going to work against streptococcal pneumonia. If it is like that, they will give one vaccine for all the bacteria. But if you observe, the vaccine for pneumococcal is different from the vaccine for meningitis. It is also different from the vaccine for Haemophilus influenza. All of them are bacteria. That is because in the adaptive immune system, antibody is developed per organism. And it takes time for the body to be able to develop those specific antibodies that is targeted just against that organism. So you have to give the body some time to be able to do that. That is why the first exposure is done over some time. And when we get to antibody, we understand that production of antibody requires the VD and VDJ gene recombination. So that is exactly the mechanism through which the adaptive immune system will work. We're going to talk about activation of the B and T cells in subsequent chapters. In fact, activation of B and T cells are 2 pages alone in this immunology, and we're going to handle each and every one of them classically. Now, let us look at the immune privilege site. The eye, the brain, the placenta, the testes are immune privileged. Why are these areas immune privileged? Now, inflammations are not expected to happen in this region. In fact, the immune cells here are very few. And those immune system and those immune cells rather are not expected to definitely cause a lot of immune responses in this location. If you cause immune responses in this location, you're going to cause a lot of problem. So we don't even want you to come here and start creating inflammatory response. No. Those areas are immune privileged. Now, let me explain something. Let me take it one step further in such a way you should understand, or you can start thinking towards it. If you look at this particular bacteria, Streptococcal pneumonia is a very common bacteria that causes pneumonia. It causes 4 basic symptoms. It causes meningitis, otitis media, pneumonia, and sinusitis. In fact, it is the most common cause of community-acquired pneumonia. Now, if you have a patient, you're the doctor, you're seated in a consulting room, and a patient came to you and say, "Doctor, I have difficulty in breathing and I'm having cough." And you definitely do a chest x-ray and you see the person has pneumonia. You definitely did sputum cultures and the rest, and you discover it was strep. Most times you don't even admit them. For community-acquired pneumonia, you just give them drug, tablets, not even IV. They go home and they get better. That is for strep pneumonia. But now, let me ask you, That same strep pneumonia has left the lungs and is now causing meningitis. If you see a patient that has strep pneumonia meningitis, are you going to give the person tablet and say, go home? No, you're going to admit that patient straight up. You will start intravenous antibiotics straight up, not even oral. My question to you is, this is the same organism, strep pneumonia is not a different organism. How come when it was affecting the lungs, causing pneumonia, you just gave the guy antibiotic and told him to go home? Now it's affecting the meninges, that is the brain, for example. You're not giving this guy hospital admission, intravenous antibiotic. The reason is because of the immune privilege. In the lungs, you have your immune cells, and the immune cells are free to definitely go on rampage to take out the bacteria. Anything they can do to take out that bacteria in the lungs, they are free to do it. So the immune cells can definitely be activated and aggressively attack strep pneumonia in the lungs. And once you add antibiotic, you support the immune cells, everything is good. But in the brain, the immune cells are not permitted to carry out that same attack. So they will be quiet looking at the organism proliferating. That is the reason why in the meningitis, it became an emergency. You have to admit, you have to use your big guns, which is your intravenous cephalosporins, unlike the pneumonia, because you know that the immune cells are not going to do much. They are not permitted to do much. Not that they cannot do much, but in that area, they are restricted. So the only chance you have of beating that infection in that area is by using the big gun antibiotic. That is the importance of the immune privilege in this pathway. Now let us move on. So let's look at the major histocompatibility complex 1 and 2. I want to play with this concept at the level of the whiteboard. So we just have about 2 pages and we should definitely round up. So this page and the next page, and we're good. So let's go to the level of the whiteboard and talk about that. Now, there's the MHC class molecule and there's the HLA gene. A lot of people don't like these concepts of MHC and HLA because it looks abstract for some people, but you just need to understand it because it is easy. Now, when you talk about your MHC, that is the major histocompatibility complex. MHCs are definitely proteins that are seen on the surfaces of cells. And those proteins are definitely produced by the HLA genes. So the HLA are the genes. The genes produces the MHC, which are the proteins. If you followed me in the molecular biochemistry, you discover that genes are the ones that code for protein synthesis. The expression of a gene is evidenced by the protein they produce. So the HLA are the gene, the MHC is the protein. Now, what is the function of this MHC? What is the function of this MHC? That is what we need to understand. Now, when we talk about the function of the MHC, now every single cells in your body has the MHC class 1. The MHC class 1 is a tag to your cell. Let's assume this is your own cells. Your own cells will definitely have the MHC class 1, which is this one. This is the MHC class 1 it will have. Now, this MHC class 1 is a tag to identify your cells and differentiate it from foreign cells. Every single cell, whether foreign or your own cells, must have MHC class 1. So your immune cells are trained to recognize your own MHC class 1. Now, that is why your immune cells are not going to destroy your own cells, because when they come and look at your MHC class 1, they will like, oh, this is our MHC class 1. We recognize this one. This one is our own. And they will pass. But when your immune cell comes to an MHC class 1, it is unable to recognize. It will become aggressive. It will lead to destruction of that particular cells. This is important when you're doing organ transplantation. For that organ to take, the MHC class 1 of the donor has to be similar to that of the recipient, so that the immune cells will definitely think the organ belongs to the person. If the immune cells peradventure senses that that MHC class 1 is not their own, you will not stop them from attacking that transplanted organ. They will attack it until they destroy it, because that is what they have been programmed to do. That is why before you go and transplant somebody, you must have to assail the HLA genes. The HLAs are the ones that produce the MHC class. So if me and you have similar HLA genes, our MHC class 1 molecule will be similar. If I give you an organ, your body is likely to accept it, and vice versa. So that is the general importance of these MHC molecules. It serves as a tag to every single cell in your body. Every single cell must have the MHC class 1. Now, that MHC class 1 is what helps your immune cells to recognize these are our own cells. And that is what helps your immune cells too, to know that these other cells are foreign. I'm going to attack the foreign cells, but I will avoid our own cells. That is the summary of the MHC class molecule. Now, if this is understood, let's get this party moving. Now, let us now focus on, let me go to the next whiteboard instead of spending time cleaning. So let us now focus on the MHC class 1. We do the MHC class 1, we come in again and do the MHC class 2. If you started this section with me, you understand that I normally talk about things from the top to the bottom. That is how I definitely go with the concepts. Now, if you talk about the MHC class 1, it is coded by HLA genes that are single genes. What do I mean? There are HLA genes that can be single or double. For example, you have the HLA-A. HLA-A, this is a single gene. You have the HLA-B. This is a single HLA gene. And you have the HLA-C. But there are double HLAs like the HLA-DQ. HLA-DQ. This is a double gene. Now, the single HLA genes usually code for your MHC class 1 molecule, while the double HLA genes we code for your MHC class 2. So because we're definitely focusing on MHC class 1 now, we'll definitely look at the single HLA genes that produces them. That is the HLA-A, HLA-B, and HLA-C. And these are the ones you definitely look at for basically when you want to transplant a patient. Now, I have already told you where the HLA-1 is found. Now, HLA-1 is seen in all cells of the body. There's only one cell that will refuse to have HLA. That is your red blood cell. I've told you those guys are something else. It will not have MHC1. It will not have nucleus. It will refuse to use any other metabolite as source of energy except for glucose. So it's a very interesting cell. Now, what it simply means is that this MHC class 1, like I explained, is a tag to all your cells. If there is a cell that has a different MHC class 1, of course, your lymphocyte will be activated. Now, what you need to understand is which of the lymphocyte responds to your MHC class 1. This is going to be important. Now, it is your cytotoxic T cell, that is your CD8. This is the one that goes scanning the MHC class 1. So CD8 scan MHC1. For example, for you to know, for your immune cells to know if this MHC class 1 is actually your own or not, it is the CD8 cells that we go and check. If it is your own, your CD8 cell will not be activated because it cannot be activated against your own MHC1. If it does that, that will cause autoimmune disease. So when it goes to check, it will tell the others, this is our person, everywhere is good. But if it goes to check and it discovers it is foreign, it becomes activated, it signals the others, and more of them will be activated, and they launch an attack. So the CD8 is the one that scans MHC class 1, and it is the one that responds and becomes activated if it observes any abnormality with it. Now, how is this MHC class 1? How does it really bring about activation of T cells? Now, there's something you have to know. The particles that will cause activation of T cells via your MHC class 1 comes from the inside. It is endogenous particle. I will explain. Now, if you look at your cytotoxic T cells, your cytotoxic T cells destroy two types of cells. Viral infected cell, this is viral infected cell, and your tumor cells, this is your tumor cells. Now, let me use the viral infected cells to explain this. Now, see what happened. Viruses cannot survive. Viruses basically don't survive on their own. Viruses usually infect your cells. Viruses stays inside of the cells. That is what they do. Most of the viruses definitely get access into the cells. Viruses are definitely either DNA or RNA. That is the level they exist. They don't exist as a cell. Your bacteria can exist at the level of a cell. That is why a virus can infect a bacteria. That is called a phage, because those guys are too small. They are just nucleic acid. So viruses finds their way inside of the cell. So most cells will be virally infected. Now let's assume this blue cell is virally infected. This black thing is the virus. Now, your MHC class molecule is a protein. From biochemistry, every protein will definitely be produced at the level of the endoplasmic reticulum. That is where proteins are synthesized by the ribosomes. So your MHC class 1 is also produced at this endoplasmic reticulum. So let's say this is your MHC class 1 being produced in the rough endoplasmic reticulum. Now, what will happen is this particular cell has virus. Look at the virus inside. Now, your T cells don't even know that this particular cell has virus. That is where the MHC class function will come in. So what will happen is that this virus, some of the particles will be carried by what we call the TAP. That is the transporter associated with antigen processing. It is called TAP. The short form is TAP. But the full meaning is the transporter associated with antigen processing. Now, this TAP will come and pick a small fragment of this viral particle, just a very small fragment, and the TAP will bring that small fragment and place it on this MHC class 1. Now you see that the antigen was placed inside of the cell. It was an endogenous antigen. The antigen came from inside and was placed on the MHC class molecule on the inside. Now, normally after production of protein, the protein will go to the side where it is supposed to function. Now, this MHC class 1 molecule, the production is done. It will now come to the surface. When it comes to the surface, your T cells will come and scan it, especially the cytotoxic T cells. Now, when the cytotoxic T cell come to scan it, this is not going to be the normal MHC class 1 because it's having a viral particle. Your cytotoxic T cell will just know that, oh, something is wrong with this cell. there's a virus inside of this cell because this is not my normal MHC1. Automatically, it will launch an attack and destroy this cell. That is how your MHC class 1 works. Now, the final thing I will tie in before I run is this. Both your MHC class 1 and your MHC class 2 will definitely have two different chains. They are made up of two chains. Now, your MHC class 1 will have a very long alpha chains, and the beta chains are very, very short. That is what you need to know. Now, the alpha chain will be this long. All this thing is the alpha chain. Now, look at the beta chain. The beta chain is this short one here. Classically, that is definitely how your MHC class molecule works, basically. Oh, my video has gone off. I don't think so. Let me unmute the house and see. Somebody said my video has gone up on the general page, but I don't think so. Let me see. Okay, so somebody confirmed that it's there. So sorry, I think it's your own network. So sorry, I think that's from your network. All right, thank you. Let's move on. So what I was trying to say is this. Now, if you look at, I don't like to be interrupted because I lose my line of thinking, but it's okay. So if you look at the MHC class 1, they have two different chains. They have a very long chain, which are the alpha chain, which is this one in black. And then you see they have a short chain, basically, which is definitely this one in blue. Now, if that is settled, let us now move to look at the MHC class 2. That's what we definitely want to look at. So we've settled the MHC class 1. Let's move the party to MHC class 2. That's what I want to dine on now. So my normal pattern is I'm going to talk about this thing from top to bottom, basically. Now, your MHC class 1 is produced by single HLA genes. Those are what codes for it. Now, your MHC class 2 will be coded by double HLA genes, like your HLA DP, HLA DQ, and HLA DR. Now, I want you to observe something. The genes are alphabetical. In your MHC class 1, it was HLA A, HLA B, and HLA C. Those are sequential alphabet. Now, in your MHC class 2 is HLA DP, HLA DQ, and HLA DR. The same way it progresses in the alphabet, PQR. Now, if that is understood, where would you find your MHC class 2? Now, your MHC class 2 is not seen in all cells. No. Your MHC class 2 is only seen in antigen-presenting cells. What cells are your antigen-presenting cells? Your macrophages are here. Your macrophages are antigen-presenting cells. Your B cells are here. And your Langerhans cells are here. So these are the antigen-presenting cells. These are the ones that have your MHC class 2. Now, if that is settled, the other important thing you need to know is the antigens. Okay, no, before we get to that, your MHC class 2 is the one that is responsible for activating your CD4 cells. So what go to scan the MHC class 2 is your CD4 cells. Now, the CD4 cells is not going to scan the MHC class 2 to see if it is foreign or to see if it is the normal body cells. Most of the MHC class 2 will definitely be that of the normal body cells. But look at the function of the MHC class 2 now. The MHC class 2 will carry antigen on top of that MHC class. So it is the one that is responsible for presenting antigen to CD4 cells. Once CD4 cells are activated, they can also activate other immune cells. So the basic function of MHC class 2 is for antigen presentation. That is why you see it on antigen presenting cells. Now let's assume that you have a bacterial infection in the blood. This red guy here is bacteria. These are bacteria here. And remember, B cells will respond to bacteria. So what will happen is this. The B cells will come. The B cells have MHC class 2 on their surface. The B cells will pick up a fragment of this bacteria on their MHC class 2. When they pick up a fragment of this bacteria on their MHC class 2, they will go and meet your CD4 cells. These are the CD4 cells. The CD4 cells are the one that scans the MHC class 2 to see if they are bringing any antigen. Now, this is your CD4 cell having what we call the T cell receptor, TCR. Now, it will scan the MHC class 2 on this particular B cell. And when it scans the MHC class 2 on this B cell, it will definitely discover that this B cell has definitely brought a bacteria antigen. It will definitely see that, yes, this is definitely an antigen, and this antigen is not normal body antigen. Automatically, your CD4 gets activated. It activates other immune cascade, and you definitely have proliferation of the immune system from there. So basically, your MHC class 2 is for presentation of antigen to your CD4 cells to definitely enable your CD4 cells to be activated and trigger an immune pathway. That is what it does. And that is why it must be carried on the surface of antigen presenting cells. Now, something that is important, how does the antigen come about? Now, the antigen for your MHC class 2 comes from the outside. Most of your bacteria are in the blood. Most of them are causing their problem in the blood. So what happens is that these bacteria are taken from outside to inside via phagocytosis, like the macrophages. Now, it is once they have been taken inside, your lysosome can definitely split them into different particles. Now, those particles can now be added to your MHC class 2 and sent to the surface. So if you look at the MHC class 1, the antigen came from the inside because the virus was already on the inside. If you look at your MHC class 2, the bacteria rather was taken from the outside. So it's going to be an exogenous route of antigen presentation, while your MHC class 1 is going to be the endogenous route. Now, when you look at the structure of your MHC class 2, they have two equal length chain. This is chain 1, and this is definitely chain 2. You can see that chain 1 and chain 2 has equal length. Classically. Now, there's a way you should remember your MHC class 1 and MHC class 2 and which type of T cells they respond to. You know, there are two basic types of T cells, the CD4 T cells and the CD8. Now, the way to remember this is for you to use the rule of 8. Now, the rule of 8 states that 1 times 8 is equals to 8. And 2 times 4 is equals to 8. So whenever you see a clinical vignette and you're confused by which of the MHC interact with which of the T cells, all you just need to do is ask yourself, this T cell, if I multiply it by this MHC, am I getting anything greater than 8, or am I getting the number 8? If you have anything greater than 8, it is wrong. It must be the exact number 8. If you have anything less than 8, it is also wrong. If it is 1 times 4, 1 times 4 is 4. It's not correct. If it is 8 times 2 is, if it's 8 times 2 is 16, is not correct. Whatever you're getting must be 8. 1 times 8 is 8. 2 times 4 is 8. So that will help you to know that your MHC class 2 will be for CD4 and your MHC class 1 will be for CD8. It makes the job easier. This is what they have on this page. So the other thing we missed out is the associated proteins. MHC class 1, we have the beta 2 microglobulin. The MHC class 2, we have the invariant chain. Look at their length. The MHC class 1, you can see how long this blue chain is. You can see how short this other one is. Same on this and on this, basically. Now, these are the HLA subtypes, basically, that are associated with specific disease. We're going to do all these things when we get into the system. At this point, you're going to be cramming. If I talk about them now, it will not make a lot of sense. By the time we go to musculoskeletal and we do the seronegative spondyloarthritis, where you have the lack of psoriatic arthritis, ankylosing spondylitis, IBD, and reactive arthritis, we can tie it to B27 and it will make sense. Now, if I'm telling you Abacava hypersensitivity and associated to B57, you may not understand that until we do microbiology, where we definitely do the antiretroviral drug, and you discover that somebody that has HIV, before you start the person on Abacava medication, you must check if the person has B57. If the person has B57, avoid giving that person Abacava. The person may have life-threatening hypersensitivity that will kill the person, but you need to have done HIV in microbiology to appreciate that. Celiac disease, we have the DQ2 and DQ8. You would have done the celiac disease in GI. If you don't even appreciate the celiac disease, you don't know what the pathophysiology of celiac disease is. How will you appreciate it's associated with HLA, DQ2, and DQ8? So these ones will definitely be reserved for when the system has been tied in. We'll come back and we'll look at this and it will make more sense. Now, let's look at the last briefly and we'll run. So this is the last we're going to look at and we're not going to spend a lot of time here. Now, for those of you who have been privileged to do a few of the MBMAs, you can definitely get the MBMAs on their site where you pay 60 USD and you definitely get it done. It's very important for this pathway. Now, if you have done the MBMA, you understand that the natural killer cells function are super important in this pathway because it will always be confused with the function of your cytotoxic T cells. Now, look at these cytotoxic T cells. Look at their function. Look at the function of the natural killer cells. Can you see that it's almost the same thing? Oh man, there's a lot of difference. This is where the pathway gets tricky. You're seeing it in the literature like this. And you may just think it is like this. It is not like this. It is deeper than this. Now, this is where they differentiated it. So I'll go to my whiteboard and I will find that at the level of my whiteboard. Then I come back. We just talk about the others. The others are things you definitely know and we run. Now, so let's quickly move. Now, see, this is, let's assume this is a viral infected cell. So this cell has virus, or this is a tumor cell. Now, see the way your cytotoxic T cells, which is the CD8 cells or the natural killer cells, this is the way they destroy. So this is either NK cells or CD8 cells. This is how they destroy. Now they create what we call the perforins. The perforins is like they are creating a channel. They are creating a channel from this T cell that will go into the viral infected cell. Now, once it has created this channel, you see now it has created a channel in the viral cell. It will produce what we call the gram-zyme. It will release the gram-zyme through this channel to enter into these cells. Once the gram-zyme enter into this cell, it will induce apoptosis and it will destroy this cell. Both your CD8 and your natural killer cell goes via this pathway. But my question to you now is, how will the two of them be differentiated? Now, see the difference. Your CD8 cells, this is your CD8 cells. Your CD8 cells only destroy, your CD8 cells only destroy viral infected cells or tumor cells that have their MHC class 1 molecule expressed. Think about it now. Your CD8 cells will definitely have to go and scan for your MHC class 1. When you notice that that MHC class 1 molecule is abnormal, maybe a viral antigen was placed on top, or maybe it is an antigen of a cancer cell that was placed on top, it will be activated and destroy the cell. Now, my question to you is this. You know, cancer cells are very smart. If the normal body cells can be as smart as cancer cells, human beings will live forever. Because cancer cells will always find a way to outsmart the host cell. Now, let me ask you, what of if these cancer cells now understand that the cytotoxic T cell is capable of destroying them because of their MHC class 1, and they now decided not to express their MHC class 1, they now hide their MHC class 1 inside. Of course, your cytotoxic T cell cannot destroy this cell because when it comes, there's even no MHC class 1 for it to scan. So automatically it cannot even know if this cell is normal or abnormal. So these particular cells have evaded destruction from your cytotoxic T cell. That is where your natural killer cells come in. Your natural killer cells understand that every single cell in the body needs to express their MHC class 1 except the red blood cell. Now, if you're not the red blood cell and your MHC class 1 is not expressed, something fishy is going down. That is what the natural killer cells will definitely assume, that why is this guy not expressing his MHC class 1? If this guy was a normal body cell, his MHC class 1 should be expressed. So on that note, I am going to break him down. So it is these tumor cells and viral infected cell that doesn't express their MHC class 1 that your natural killer cells comes in and take care of. So this is the difference that they hid in between the line for the two of them. And that is what you need to know. So your NK cells and your CD8 cells both destroy tumor cells and viral infected cells. But the difference is that your CD8 cells will destroy tumor or viral infected cells with MHC class 1 expressed. NK cells, on the other hand, will definitely destroy tumor cells or viral infected cells that have their MHC class 1 molecule hidden or underexpressed. The natural killer cells are also lymphocytes, but a lot of us don't know that. You have to add that to your knowledge bank. It can also be involved in antibody-dependent cell-mediated cytotoxicity. I've already tied in the most important thing. Now, when you look at your B cells is the one responsible for production of immunoglobulins, basically. They are the ones that produce immunoglobulins in the body normally, classically. So that is the humoral immune system. Now, they are also part of the antigen-presenting cells. That I told you. Now, because they are part of the antigen-presenting cells, automatically they are responsible for presenting antigen to your CD4 cells. They have the MHC class 2. Of course, because they produce antibody, they can also have memory cells. They are part of that adaptive immune response we talked about. Now, when you talk about your T cell has the CD4 cells and they have the CD8 cells. Now, see what you need to understand. The CD4 cells don't really have like a specific functions per se. The CD4 cells are helper T cells for a reason. Now, anything you want in the immune system, tell the CD4 cells, they will make it happen for you. That is what they do. If, for example, you say, oh, what I need now, I have what I have now, what this infection that is ongoing now, what the immune system need is cell-mediated immune system to shut it down. What will happen is this: your CD4 cells will differentiate into the helper T cell type 1 and produce cytokines that will activate the cell-mediated immune system. Now, tell the helper T cell that what you want is humoral immune system. I need antibody to handle this infection. It will go to the helper T cell type 2 and it will definitely activate the humoral immune system. You have abundance of antibody. If you tell it, oh, what I want right now is neutrophil, it will go to the helper T cell 17 and give you neutrophil. If you tell it, oh, this inflammation is overwhelming, I want you to shut down the immune system, it will go to the regulatory T cell and shut down the immune system. So the CD4 cell is just tell me what you want and I'll make it happen. So we're going to practice some questions. This is okay. I will definitely allow, I will unmute the house. I'll have to unmute the house. And I'll definitely allow queries to come in. But before I'll do that, I want to write out, I will definitely publish these videos. There was a lot of comments on the cardio videos, definitely. There's a lot of comments on the cardio videos, cardiophysiology videos. People were trying to reach me as much as possible, but they don't have a way to do that. So I'll definitely put out my WhatsApp number on the white screen. This is for people who will definitely watch the videos that are not in this group. So that instead of asking plenty questions on YouTube, how do we contact you? They can definitely reach me via the number. All right, so this is where I stop sharing my screen, and this is where we definitely get your queries. So please hold on till the end of the class so that you practice the UWORD sections for the things you have learned.